So OCT is a non-invasive method for imaging ocular tissues. It uses light to create cross-sectional images of ocular tissues with a micron-level resolution. The OCT images are representative images of ocular tissues based on the amount of light scattered and reflected. So an A scan is one scan from anterior to posterior, and then a B scan is a collection of these A scans, and then you get this sort of slice of the retina, which we're all used to looking at. When you get a lot of these B scans together, you can create a cube scan, which is sort of like a volumetric 3D version of the retina. A raster scan is going to be more of a high resolution scan, but then you only get 5 slices. A radial scan is similar, it's also a high resolution scan, and it's centered around the fovea or the area of interest. So looking at normal OCT, there's a lot of layers that you can see with OCT, and some of them are going to correlate to what you see anatomical and histological slides as well. So the basics is really the homogeneous structures. They allow light to pass relatively undisturbed and reflect little light. So they're going to appear as dark gray and black. So this is something like the vitreous, the outer nuclear layer, where the nuclei are really tightly packed and in more of a regular structure. And then of course serous fluid, because that's mostly water. Heterogeneous structures, they're going to reflect a lot more light. So these are going to appear as light gray or white. The retinal nerve fiber layer, the outer plexiform layer, and fibrous scars are going to be much more reflective. So back to our normal OCT. So we can see the retinal nerve fiber layer is almost white here because it's very reflective. And then if we look out at the outer nuclear layer, or the vitreous, it's very, very dark. And then of course we have our outer bands like the RPE, the ellipsoid zone, and external luminary membrane, which are all very important because they correlate very well to visual acuity. So the way I look at a retinal OCT scan is first look at the macular thickness map. And this has a lot of information in a really small report. So it's literally just one sheet. First thing I do, which we should all be doing, all our diagnostic reports, is making sure we have the right patient, the right date, and of course that the signal strength is good. Then I go over to a thickness map, and a thickness map gives me a great overview of the macula in this case. This is also going to be featured with the quantitative map, which gives actual numbers to how thick the retina is. And then of course you look at the B scans underneath to make sure that you're actually centered on the fovea, or if you're looking at things like edema or drusen or any lesion out there. I feel like vitreomacular interface disorder is a great place to start because we all understand what's going on. We know that the vitreous is pulling on the retina, and when it pulls, it's going to cause retinal thickening. So looking at the retina maps, you can see there's central thickening, and that correlates with what we see on the actual B scan, where we're looking at the retina and it's pulled up just in the fovea. So this is a raster scan in that same retina map we were looking at. So the way I like to examine the actual B scans is I always try to find the RPE because it's a relatively thick and bright band, so it's usually very easy to identify in any OCT scan. Then depending on the pathology, I'm going to actually go anteriorly or posteriorly. So in vitreomacular retraction, I know that the pathology is going to be more anterior because it's the vitreomacular interface. So as we move from the RPE more anteriorly, we see this sort of tent-like retinal cyst because it's being pulled up by the posterior corticovitreous. It's important to get an OCT on these patients, not just to identify what's going on, but also to know what to do going forward. A lot of times, vitreomacular retraction can resolve on its own spontaneously, and it'll look like this image on your right, where the traction releases and you have these little cysts that eventually will sort of snap back. But sometimes this can worsen and the traction gets significantly worse and you get a full thickness macular hole. And those cases, of course, should be sent over to retina so they can consider intervention. So vitreomacular adhesion is something that gets thrown around a lot, but it's actually non-pathological. So the vitreous and the retina are going to be attached in everybody at some point. And at some point, that vitreous is going to sort of pull away from the retina, as you can see here. But if there's no changes to the retinal contour, it's just vitreomacular adhesion, and this is a benign finding. Some of the patients who develop visual macular traction will get these full thickness macular holes. And here you can see that the retinal cysts actually are in part of the retina which is being pulled away by the traction, and that's why you have all the tissue loss foveally. And that those retinal cysts, they correlate to the thickening on the macular thickness map as well. So you can see some perifoveal thickening. And in this case, the posterior cortical vitreous is actually pulled away. So this patient sort of has like a PVD at this point. The importance of looking at B scans, in addition to just your retina map, is not just to see what the pathology looks like in higher resolution, but also to make sure you're looking at a few different slices. So these two slices are of the same patient at the same time. One is just through the center and one is a little bit off axis. If you were only looking at the scan on the right, you would think that maybe this patient just has macular edema, maybe diabetic or cystoid macular edema after cataract surgery. But if you go towards the center and look at the other slices, you can see that it's actually a full thickness macular hole and that the off-axis scans are just the peripheral portion of that macular hole. And then we also have lamellar holes and pseudo holes. A lamellar hole will have mainly just inner retinal tissue loss, that the outer retina is going to be relatively untouched. And then a pseudo hole is actually when you just have an ERM, which is changing the foveal contour, but there's no tissue loss. So you get these sort of squared out foveas, but the VA is great in those patients. Looking at epiretinal membranes, on the retina map, you usually get some thickening, and then that's going to correlate with what you see in the B scan, where the retina is slightly thickened. Now, ERMs are these sort of fibrous sheaths on the vitreomacular interface, and if there's really no traction, you don't have to worry about them too much. The VA is pretty good, and you don't need to intervene surgically. But if the ERM gets worse, like the patient on the right, you can see there's more traction. You can actually see the fovea is beginning to detach. So these patients are really the ones that you want to get a retinal consult on because they can progress to actual vision loss. What I like about the ZEISS is that they also have this nice progression map where you can pick two different OCT scans and it'll actually show you the difference between them. So of course we want to make sure we have the correct dates and that the scans are actually registered, so point to point they're going to correlate. And then we can see on this map that it's actually thickening centrally, which is correlating with the changes in the ERM where it's growing and putting more traction on the retina. So there's a lot of progression going on. You might want to send these patients off to retina to consider surgical intervention. Or sometimes if the patient's asymptomatic, you can continue monitoring it, especially if there's not much change in the retinal contour. So looking at all the vitreomacular interface disorders together, we can see really the whole spectrum of these diseases. And with fundoscopy, sometimes it's a little bit hard to figure out where you are, and sometimes it's not so reliable to base your diagnosis solely on visual acuity. So that's where OCT really comes into play. OCT will give you the diagnosis 100% of the time. An important masquerader, which is relatively rare, is solar retinopathy. The reason why is because you have this outer retinal sort of cavitation, which might look like a retinal hole or a macular hole, but in fact there's no traction. It's not caused by an ERM or the vitreous pulling away. It's just actual loss of tissue. Now we're going to move on to differential diagnosis of yellow-white lesions. So these lesions, drusen, PDDs, exudates, these sometimes can look very similar on fundoscopy, especially if you have a patient with medial opacities or sometimes patients that just can't sort of sit and fixate for long periods of time. With OCT, you'll always be able to diagnose these lesions with 100% certainty because they're in completely different layers of the retina. Drusen, for example, are going to be in the outer retina under the RPE. So you can see that the druse itself is a hyperreflective area underneath the RPE and it's pushing the RPE up. A pigment epithelial attachment looks very similar where the RPE is raised, but looking at them back to back, you can see that the PD is hyporeflective because it's serous fluid, whereas the druse is going to be more hyperreflective because it's full of sort of like lipids and other byproducts. So with OCT, it's really easy to tell the difference between the two. Looking at exudates, these are usually in the middle of the retina, so around sort of the outer plexiform layer. And these are going to be really hyper-reflective. In fact, they are going to create a shadow on the OCT where anything posterior to the exudates is going to be blacked out a little bit because the signal can't penetrate. Looking at cotton wool spots, these are lesions of the retinal nerve fiber layer. So these are going to be very anterior. So we can see that the cotton wool spots are these little elevations within the retinal nerve fiber layer. So they're not below it, they're not on top of it, they're actually within the retinal nerve fiber layer. Something that can masquerade as cotton wool spots is myelinated retinal nerve fiber layer. Now the patient on the left, that you'll probably never mistake for a cotton wool spot because it's such a large area and it's isolated. But on OCT, you definitely won't mistake it because the myelin is so reflective that you can't see anything posterior to it. It's going to cause a tremendous shadow. And then the patient on your right, in fact, that's also myelinated retinal nerve fiber layer, but it looks like a cotton wool spot. So if you have a patient, maybe it's 20 years old and all of a sudden you see a lesion like this and you're concerned it's a cotton wool spot, you can always do an OCT to really figure it out before doing any sort of lab serological workup. And then looking at these back to back, you can really see that the myelinated retinal nerve fiber layer is going to be much more hyper-reflective than the cotton wool spot. You can see the tissue be more posterior to the cotton wool spot, whereas with the myelinated retinal nerve fiber layer, you can't. Looking at epiretinal membranes, we already saw a few of these, that it's really just a sheet on top of the retina. So it's going to be a fibrous sheet on top of the retina, which is sometimes going to cause traction, or sometimes it could just sort of gently grow on top of the surface. Looking at all these together, using OCT, you can really make the diagnosis 100% of the time. That it's much easier than doing it with fundoscopy because there's really no issue with trying to figure out, is that kind of wool spot, or is that an exudate, or is that a drusen, based just on appearance, because some of them can look very, very similar to each other. And of course, it's important to get the right diagnosis because your management is going to be completely different for a lot of these lesions. And then look at macular edema. So macular edema is a non-sparing term for any time you have fluid within the macula. Diabetic macular edema is a lot of times what we see, and you're going to see these little pockets of thickening on the retina map, which correlates to the quantitative retina map, and of course correlates with what we see in the B scan. We see these retinal cysts, and you can sometimes see exudates along with it as well. And then the left eye is very similar, though a little more mild. Pseudophakic cystoid macular edema, so in patients who have had cataract surgery and then end up getting edema, will also look very similar. You're going to have that thickening on the retina maps, and that's going to correlate with what you see on the scans. It gives you a great view of the petaloid cysts, and that will help you distinguish this form of edema from maybe diabetic macular edema or something else. Looking at these back-to-back, so a case of pseudophakic edema and diabetic macular edema, you can see that the diabetic macular edema on your right is much more irregular, and it's not centered on the fovea and doesn't have that nice petaloid appearance. Though if you look at just the retina maps, they look very, very similar, and I don't think you can really distinguish it based just on that. Looking at macular edema secondary to branch retinal vein occlusion, it's going to be very similar to diabetic macular edema. It's going to be asymmetric, but it's usually going to follow along where you have the retinal vein occlusion. So it's important to see where you have that vascular remodeling and which actual vessel was occluded. And that'll help you figure out, is this diabetic macular edema, or is it branch retinal vein occlusion, or something else going on. Now, choroidal neovascularization, a case like this, you probably don't even need OCT to figure it out, because this is a really tremendous net here with a lot of edema. And you can see there's the hyperreflective net, which is all the blood vessels that are growing along with the fibrous tissue. And then you have the fluid, and then you also have some exudation. Looking at a much more mild case, so this case on fundoscopy, you might see maybe a little bit of blunting of the foveal reflex, but it won't be a traumatic hemorrhagic response like you would in this case. So again, looking here, you have that small net, and then you have the fluid right next to it. And this is important to make sure, one, that you know exactly what you're looking at, so you know to send this over for treatment. But two, you can also co-manage this with the ophthalmologist to see if anything is improving, worsening, or staying the same. And that can sometimes be important when you have to send the patient back. Central serous chorioretinopathy is another one of those conditions where it might be hard to tell exactly what's going on with just fundoscopy. Looking at the OCT, we have the edema on the B scan and on the retina map. And then we see this little PD, but it's not really a hemorrhagic PD like you have in choroidal neovascularization. Very often you'll have central serous, you'll have the serous detachment of the retina and then also of the RPE. But it's very, very important to make sure that it's not a vascularized PD because that can happen in these cases as well, though it's more rare. Looking again at a progression map, which is important for central serous because initially that's how we manage these patients. We just sort of wait it out a little bit, especially if it's the first time that we notice that this patient has central serous. Unfortunately, in this case, this patient ended up actually getting worse after a few weeks. And we can see the edema on the left on the initial visit, and then the worsening edema on the right. So this patient actually sent over to retina so they could possibly offer some treatment. Unfortunately, this patient didn't go to retina and eventually came back to me. So that worsening edema foveally actually improved, but then he ended up getting another area of serous detachment superior to the fovea. So he went to retina the second time I sent him. An important masquerader for macular edema is MacTel type 2. These patients a lot of times will have little dot hemorrhages temporal to the fovea, but when you do an OCT on them, they don't really have any retinal thickening. But they do have these little retinal cysts, which sort of like early edema. But when you look at the thickness maps, it's actually retinal thinning and atrophy. A good way to tell the difference between MacTel type 2 and macular edema is that these patients actually have this what we call internal limiting membrane drape, where the internal limiting membrane just sort of drapes over these little retinal cysts, and there's not going to be any thickening of the retina. It's actually going to be atrophy. Something that you won't really see too often, but it's another potential masquerader of macular edema, is choroidal folds. And these patients, they look very strange with fundoscopy. They sort of have these darkish bands going across the fundus, and you're not really sure what to make of it. It looks like maybe it's thickened, it looks like maybe not. Really hard to tell. So when you do an OCT scan, if the choroidal folds are horizontal, you don't really see much. So looking at our top OCT, you don't really see too much. Maybe a little irregularity of the RPE, but definitely no edema or anything like that. But then when you do a vertical scan, and you're actually going through the choroidal folds, you can really see all those changes in outer retina. But again, there's no fluid accumulation, and really it's just a little disruption of the choroid and then the retina as well. Some of these cases could be idiopathic, especially if they're symmetric, but it's important to make sure it's not due to scleritis or retrobulbar mass. So let's look at some pigmented retinal lesions. Choroidal nevus is something we all see commonly in every practice. And the important thing here is to remember it's a choroidal nevus. So we're looking at RPE, but we're not going to look anteriorly. We're actually going to look posteriorly because that's where you're going to see the nevus. You don't really see too much because all that pigment is going to absorb your retinal signal and it just ends up being like a shadow. Again, that shadowing effect is going to be there because of the pigmentation, but overlying that shadow, you can see there's going to be some choroidal thinning, which happens very, very often with choroidal nevi. Now, as opposed to melanomas, which tend to be very elevated, here the retina is basically intact. Chirpy is something that I think we should understand more on a cellular level. So the normal RPE is going to be one layer of RPE cells. Hyperplasia is when you're going to have more cells. Hypertrophy is when the cells are larger, but there's the same amount of them. And then in a chirpy, it's when you have those hypertrophic cells, but they actually have more pigment in them, which is why they seem so dark on fundoscopy. Now, this is a case from Jerry Sherman, who was one of my mentors. So thank you for the case, and I have to give him a quick shout out for that one. Looking at the RPE, you see that it's thickened, and there's really nothing posterior to it, unlike in that choroidal nevus. But if you look anteriorly, you you'll see that outer retina is really deteriorated, and in fact, the inner retina starts collapsing down. This is happening because the outer retina is going to atrophy away because the chirpy can't sort of nourish or accommodate that outer retina. Looking at a chorioretinal scar, these are very often due to inflammation, which is a very irregular reaction within the retina. And this will very often atrophy the retina to a significant extent, so you get almost no retina overlying that pigment hyperplasia. And you can see that the RPE is very irregular. And then there are these little retinal cysts just because the retina is being pulled down because there's nothing to support it. So looking at all three of these back to back, even though on fundoscopy they might look similar, on OCT you can always tell the difference between all three. So looking at AMD, we all have these patients, and drusen is an interesting term because we call a lot of things drusen, but we can actually subdivide them a little bit. So looking at cuticular hard drusen, the RPE is going to be overlying that single druse, and it's actually going to be thin on the apex of that druse. Soft drusen tend to be larger and fluffier, and the RPE is usually relatively intact overlying those druses. A subretinal drusenoid deposit is actually a little bit different. It sits on top of the RPE, even though fundoscopically it might look very similar to cuticular hard drusen. When we see all these back to back, we can really see the difference where in the cuticular hard drusen, that apex of the RPE is thin. In the soft druse, it's pretty regular. And then subretinal drusenoid deposit, the RPE is below that lesion. Geographic atrophy is when you really lose that RPE and you end up getting a lot of outer retinal degeneration. So again, that inner retina tends to collapse down. You end up getting a window defect because now the RPE is not reflecting or absorbing any of the OCT signals, so you can really see into the choroid with great detail. And then choroidal neovascularization we already went over, where you see the net, which is hyperreflective, and then of course you're going to have the collection of fluid and exudates. An important masquerader to AMD is adult onset foveal macular vitelliform dystrophy. These lesions are going to be foveal, and they tend to be very symmetric. And the issue with these is that in adult patients, they don't really tend to progress too much. And of course, for these patients, you wouldn't really treat them the same way you would your AMD patients, like talking about AREDS 2, 4 mil, and such. Something else that comes up very often, especially in patients that are seemingly too young for AMD, like maybe your 40-year-olds, your 50-year-olds, are these pachychoroid pigment epitheliopathy changes. So they look very similar to drusen or maybe RPE changes from AMD. They happen in young patients, and of course it can happen in old patients because all our young patients will grow old at some point. But they're not due to AMD. They're due to these changes in the choroid, which then sort of end up affecting your retina. So you could think of this almost like in central serous as well, where once the fluid accumulation goes away, you get these RPE changes. And then the important thing to look at these pachychoroid spectrum disorders, which includes PEDs, central serous, and this pigment epitheliopathy, is that you have this choroidal thinning overlying these dilated vessels in the choroid. So very often under the pigmentary changes or under a PED or under serous detachment, you'll see that you'll have a little bit of choroidal thinning of the choriocapillaris specifically. And then choroidal folds, we already looked at it. Again, it could be a macular edema masquerader, but there's no net here. There's no hyperreflective lesion that you can see. It's really just the RPE sort of undulating and then affecting the retina above it very minimally. So this is really a lot of the basics of OCT analysis, at least as it pertains to retinal pathology. And it really shows how not only is it an indispensable tool for diagnosis, but also management of these patients going forward. Helps you figure out when you should follow up these patients, and it also helps you figure out what you can keep in-house versus referring out. And the big thing is that the more OCTs you do, the more comfortable you'll get with it, and then eventually you can look at any lesion with OCT and diagnose it very, very quickly.